Okay, let's come to order. I don't know if we have a quorum yet, but we're not going to vote for a while on anything, so we'll get a quorum, and we have to have a quorum to vote, just so people know. Headline news, Kurt Rutzen still needs a job. Let's see, we talked about that before. Yeah, he would be an excellent employee in so many ways, so I can vouch for him. You know, in keeping with the need for more revenue into the state, we're going to start doing other commercial announcements, so feel free to bring those to us. Anyway, so we have a lot to work on today, and we're lost a few minutes. We lost 15 minutes because of the floor session. But I think at the end we'll be satisfied we have a pretty good outcome. We'll have to be done for sure by 2:45. The order of the day is going to be Senate File 3062 with Senator Wiklund. When the people discuss that bill, if you could kind of keep your discussions to the policy element. I am not confident there's going to be a lot of money we'll have available to put into any of the monies in there. And so if we do actually get a target and there's some money, you guys can join the scrum for that. So that'll help us kind of keep pointed on that. And I also want to comment that it's an aggressive bill with a lot of good stuff in it, but at the end, we need a consensus of the community, and frankly, we need DHS to at least agree generally so that the House will even look at any of it, so they have kind of a relationship like that. So, but we do want to do all we can do to get rid of the paperwork, to focus on the individuals who really need our care. We still want to be here next year, and I'm just sick and tired of reading reports about people who aren't here. So that's the focus of that. Then we're going to change gears to talk about some residential matters, living. And I think just because we have a hard time funding Senate File 3390, we'll take that up last if we have time. But certainly Senate File 3389 will be the main one we want to spend our time on. And so if we're lucky, we'll let any testifiers that haven't had a chance to talk about about 3389 talk about that. So with that, I think Senator Wiklund and testifiers, we've got about a half hour or so that we can spend on Senate File 3062. So Senator Wiklund, if you want to move that to get it before us, we're going to be laying it over. We're not having any amendments to take out the money. We're just not going to focus on the money. So Senator Wiklund, I know you have a presentation in mind, and then Mr. Elwell, Mr. Zerbies, and Mr. Walsh are here to comment as well. So we've already had a limited view of this bill, and now we're going to get some more. So Senator Wiklund, thank you.
Thank you, Mr. Chair. Yes, I'd like to bring Senate File 3062 before us, and can we move the amendment that is posted to vote on, just to get that taken care of? So
absolutely. Let's just move that as a, usually I like authors' amendments to be explained, but it's the first real hearing, and we'll just get it in the shape you would like, and then we're going to be discussing the bill in a more unusual format than going line by line through it. So yeah. Do you want to move the A1 then, Senator Wiklund?
Yes, I'd like to move the A1.
Okay. Everybody, do we have a quorum?
Oh, yeah.
We have a quorum. Okay, good.
Okay.
So anybody, well, do you have questions about it, or anybody uncomfortable with that procedure? All in favor say aye.
Aye.
Opposed? It's adopted. Senator Wiklund, your bill.
Thank you, Mr. Chair. Yeah, I'm happy to be able to discuss Senate File 3062 once again in your committee, and I really appreciate your giving it another opportunity for us to talk about it. As you'll recall, we had on February 10th, I believe, we had a very full discussion about substance use and the impact on communities, and we had excellent testifier, Dr. Kelly, who talked about the whole process for people, or that people have been going through in terms of addiction and recovery. And this bill is meant to address the fact that right now we're seeing, record overdose deaths and more substance use, and yet we're also seeing fewer people are receiving treatment. So we need to find ways that we can better assist people who need help. So the bill is quite comprehensive. A couple other points I wanted to mention. We requested a fiscal note on the unofficial engrossment, and that was submitted, I think, a week and a half ago. So we will have that, although, as you mentioned, we may not have the ability to fund aspects of this, but we wanted to get a better idea of what the costs were. And we have been working with DHS. The testifiers have been working with DHS over time and have received technical assistance, a first draft of technical assistance on the 25th of February. And so we're also going to be meeting with them next week to go over that together and to talk about the different points that they've raised. So just wanted you to be aware that that work is in progress and will continue as we go on. So today there are two people, excuse me, planning to present the bill, Amy Delwo and Brian Zerbies, and I will let them, Amy Delwo is going to begin with Article 1. So, thank you.
Well, thank you. Looks like they're virtual. And then we're going to hear from Mr. Walsh after that. And then I think we'll just go right to DHS for their comments about the policy. And Sarah Wiklund, I don't know if we've requested a fiscal note, but I just talked to Mr. Yates that we should request one if we already haven't. So does that sound?
We have requested one.
Okay.
It was submitted by Dennis Albrecht.
Perfect.
Submitted it, and I don't have the date, but it's over
Sure.
a week ago.
Okay, well, you're way ahead of me. And so we would like to know what things cost, just so if we ever do find the money. So anyway, so welcome, Ms. Delwo. Nice to have you here.
Thank you, Mr. Chair. My name is Amy Delwo, and I am the Vice President of Public Policy at New Way. But I'm here today as the March President-elect. I want to thank Senator Wiklund once again for carrying this bill, as well as the committee for their time. I will be resketching Article 1 for you, and then my colleague, Mr. Zerbis, will be resketching Article 2 and 3. In terms of the first article, it's mostly about supporting people who are newly in remission from substance use disorder. And largely it is about mitigating some of the triggers, the key triggers that they say cause the recurrence of symptoms, or what others might term as relapse. And so in Article 1, one of the things that we do there is that we're seeking to waive the fees for birth certificates and state identification for individuals who are medical assistance eligible. This helps them to re-engage in the community, whether it be through job or housing and the like. And then the next item in the bill has to do with a 6-month post-discharge transition benefit once the patient has completed treatment, and that's 15 hours or more a week of treatment. So that would be a medium intensity residential or high intensity residential or an intensive outpatient program. This includes basic social determinants of health, such as a housing stipend, food, childcare, and then transportation that is not medical assistance covered. And many of these individuals, a lot of times have a background that is a barrier to securing rental housing. And in this article, we also offer a housing fidelity bond that would help any landlord feel more secure in renting under these circumstances. So it allows for a bond between $5,000 and $25,000 for 6 months and can be extended up to a year. And then also we want to assure that any patient who is actually discharged is able to periodically reconnect with their counselor, and that they've already built a relationship with, that they know and trust. And this bill makes that logistically feasible to do. Now, there's 2 other points in Article 1. The first allows for a greater diversity in the number of guest speakers that can be invited into a group therapy session, while a counselor is certainly in the room, but it opens the door to more individuals being able to share their story and their expertise. But the counselor will then do the processing and treatment component of that discussion. And then finally, we are requesting that DHS give providers greater access to helpful data that will allow providers greater insight to their own performance and the outcomes of their patients, so that they're able to improve their performance over time. And there's very little data that we are getting currently in terms of when we submit data to the department. And so we'd like to see that. With that, I'd like to turn it over to my colleague, Brian Zerbis, and I'll stand for questions after he's completed.
Perfect. Mr. Zerbis, welcome.
Thank you, Mr. Chair. For the record, Brian Zerbis, Vice President of North Star Behavioral Health, a substance disorder organization, here on behalf of March and the Government Affairs Committee. So first with Article 2 is our workforce article. Within that, there's a component to extend internships for individuals that are working an internship in a program after they complete their coursework and submit their licensing application, that they can have up to 90 days to continue working in that program in that capacity. The next component in Article 2 is regarding HIV training for staff. On this one, it is a request to have DHS update and outline the content required for that training for providers. The third piece of Article 2 in workforce is a two-parter. It is addressing co-occurring staffing requirements. So the programs that have a co-occurring rate enhancement currently have 25% of their staff be mental health professionals. There's language to adjust that to have a necessary staffing amount of mental health staff. The other component of that is the number of hours and documentation of hours for residential programs. The low, medium, and high hours needed in residential programs are 5, 15, and 30 hours per week, respectively. There are times when clients are going to appointments or ill, not able to attend for some hours or part of a day, which makes them drop below the 30 hours, for example. So this change would have the provider document reasonings for why the person missed hours and their efforts to get them re-engaged. The fourth component in Article 2 is on a temporary rate increase. So last session, there was a rate methodology study that, or bill that passed out to have a rate methodology study completed by 2024. So this temporary rate increase would, in the event if those, that study and recommendations don't happen in 2024, that there would be a rate increase for all substance use disorder providers, not just those that are currently enrolled in the 1115 demonstration project. And then the last component in the workforce article is regarding a direct care staff wage increase. So this component was modeled after the HCDS wage increase last session that had a pass-through for direct care staff in SED programs, those that are doing direct work in the trenches, working with our clients to be able to have a wage increase. The third article is regarding service preservation access. So 5 components in this article. First one is for withdrawal management programs to expand the types of Department of Health supervised living facility to add a Class A license, which is for serving ambulatory individuals, to have that be allowed for a withdrawal management program. The next section is regarding documenting timelines for significant events. So clarifying that when a significant event happens, that a program would have up to 24 business hours to be able to document that significant event, as to opposed to currently the language is immediately. That would allow programs a little bit of time, or the counselor a little bit of extra time to clarify the timeline requirements. The third component or section is extending treatment plan review timelines. Currently, treatment plan reviews are required to happen every 7 days. This language would extend that to be every 28 days, unless if there's a significant event or if there's a reason to update more often. A council would still need to do that. The fourth section of Article 3 is adding substance use disorder reimbursement rates to an existing report put out by DHS. This current report is for reimbursement that county-based purchasing plans and managed care organizations pay for medical services, dental services, mental health services So this would add in substance use disorder to that report. The last item to touch on in Article 3 is extending the deadline for the paperwork reduction report. So there is, last session, a report was directed to be created. Based on the funding and approval, that report will likely not be ready by December of 2022. So there's language extending the deadline to allow the selected vendor to work with providers. So that concludes my part of the overview, Mr. Chair. I want to thank Senator Wiklund again for carrying the bill, and for you and the committee for giving us an opportunity to come in and speak to it.
Well, thank you very much. Senator Wiklund, that's kind of the walkthrough. Did you want to highlight anything, or should we just go to, what would you like?
I think if you want to go, if there's another testifier, and then if there's general questions or if people have questions.
Yes, I think we'll do, Mr., yeah, come on up. And so we'll talk to you. And then I'm not sure if anybody has many questions, but we can do that, and then we'll hear from the department for sure. I want to give them ample time. So welcome, Mr. Walsh. Welcome to the committee.
Thank you, Mr. Chair and members of the committee. My name is Tim Walsh. I'm the Vice President at Minnesota Adulting Teen Challenge. Normally, I'm in front of you testifying in support of March bills, and that's actually mostly true today. But today, I'm representing Minnesota Adulting Teen Challenge. I do have one exception in the bill. I think the bill is well crafted. I think it's critical. I think it meets urgent needs. And I hope we keep that in mind as I go through the rest of this. So it's Article 1, Section 7. DHS has said this section is actually not implementable, and they have lots of reasons for that, but my concerns are deeper than that. I have serious policy concerns about that section. First of all, when we're talking about even the fiscal policy here, the extra funds here, because there are new benefits here, would drain out of the behavioral health fund. And we have serious concerns about that. Also, the way it's written, and I am responding to just the way it's written, a person could be in inpatient or outpatient treatment for 15 hours for 1 week even and receive 6 months of benefits as a result. And the way it's written, it leaves open that a person could receive another 6 months after every treatment episode, whether that's intended or not. That's the way the language could read. And then there's no limit, there's no terminus in the language, and there's no requirements on the person who receives the benefit. So I don't think that's good for the people receiving it. I don't know that it actually meets a desperate need for those people who have only done 15 hours of minimal treatment per week. Second is, DHS rightly pointed out that this kind of benefit set takes usually years to develop, to base it on evidence. And when you look at some of the housing and economic assistance programs, they're tightly designed, and they have reporting requirements, they have accountability requirements, they help to bridge people to stable employment, stable housing, not just temporary housing, self-sufficiency. And this bill, the way it's constructed right now, it has no evaluation component, and what it will actually effect is a series of temporary housing stays, continued unemployment, and actually dependency on financial supports. DHS has also rightly said that this is a financial benefit bill. This is the set of financial benefits, and it's not just braided funding. These are new these are new financial benefits that are on top of this. And wherever it does rely on current benefits, it says whichever is greater. Whichever is greater, and whichever is greater means that there's going to be funding over and above what is currently offered. So this, it looks like it's at least $1,000 extra per month per person who might be eligible for this program. But our most serious concern about the policy is actually good policy for substance use disorder treatment and recovery is based upon how people early in recovery or remission actually think and behave. That's what it's based upon. It's not based on good intentions or our notions of the way things should be. It's the way things actually are. And when somebody goes through detox, and then they go through withdrawal, and then perhaps they've only done a few weeks of 15 hours of treatment per week, they are actually at their most vulnerable for relapse at that point. And now you're giving them financial benefits. And And in our experience, when you give somebody a whole lot of money who's early in remission or early in their recovery, that tends to be a trigger. I think this is actually a risk. I think it's a risk for relapse to have that generous of benefits for someone just coming out of treatment. So a good policy in this area, I would argue, actually helps a person to build up true recovery capital. That's actually what's research-based, is recovery capital, and that means stable housing, not temporary, stable employment, stable supports in the community, not formal supports within the treatment system, and building up coping skills rather than a person being able to be dependent on these benefits. So that is what's predictive of stable recovery. And that actually is what is considered to be the housing first model. The research on housing first is not temporary. It's stable housing. And by the way, there's multiple options for housing right now, which could be accessed by people in the system. The last point I'd like to make is that the sober home study is pending. And so when we use terms like recovery safe, I actually don't know what that means. I've never heard of that term before. And right now, that whole study is looking at what is a sober home, what is sober, are they sober? I think for the most part, and for most people, sober homes are actually an excellent opportunity for people to stay in sobriety. But we're going to find out from this study. And so when we talk about someone being a safe recovery safe housing, what it really comes down to is housing of that person's choosing. And so now there's 6 months of benefits. And so then what happens, or what can happen, is of course a person can get 6 months of benefit, relapse, go back to treatment, get 6 months of benefit, relapse, go back to treatment. So it can result in an endless carousel of going from relapse to treatment to 6 months of benefit, the way it's currently written. So those are our policy concerns, Mr. Chair and members of the committee.
Well, thank you, and otherwise you'd like all the rest of them, I know that we talked about.
Yeah, that's
a number.
right. I just want to be absolutely clear on that. We support the rest of the bill. It's critical, it's urgent, It's really good thinking in the rest of the bill. It's just one section.
No, I'm grateful, and this is meant to be a forum just like what you have, and it's just a good discussion. The good news is if our target's real low, never mind. So, but it's actually good to discuss what would be the best if we could do it. And then the sober housing thing you reminded me of, we were fully intentional about trying to do something this year, if you remember the dialogue last year. We're doing something, and that comes out the middle of March. Is that right?
I don't know off the top of my head. I
Anyway,
think so.
I kind of remember that. So I think Senator Housley, didn't you work on that before? Anyway, so I'm interested in trying to find some way to get that standardized, and it's in the same topic of substance. So, Sir Wiklund, should we just go to the department, or do you want to say anything?
Well, I think Ms. Delwell might have information that she'd like to respond to the concerns. I mean, I think there's an opinion that, some of these supports are not available today, and that's why the bill brings them forward. So I'd like to have her ask if she could give a little bit more of a response. Thanks.
Yeah, Ms. Delwell, you want to do a minute or two, and then we're going to move to DHS, and this is obviously going to be discussed more. There's a series of clones everywhere. It's like some kind of science fiction movie, I think, where all these have gone, so clones everywhere. So, Ms. Delwell.
Thank you, Mr. Chair. And thank you for inviting me to say a couple words. The first is that what's in the bill, and perhaps it's maybe we pointed to the wrong section, but this is for people who have successfully completed treatment of 15 hours. So getting 15 hours a week. And so oftentimes individuals who are in a medium intensity or a high intensity residential environment and complete treatment successfully do so after 45 days or, 60 days or something along those lines. And it's also for individuals that have completed an intensive outpatient stay. And a lot of times that's after, 3-4 months. And so I just wanted to make that observation. In terms of stable housing, I think that the goal is to get folks to stable housing. And so what we've heard from clients and patients is that at times they will find another individual who is working a program, and that they may go and rent an apartment together and begin to kind of put their roots down, if you will, in a community. And so the goal of the housing stipend was specifically, it certainly doesn't cover what the rental cost is for a one-bedroom apartment, which generally you might expect to be about $1,200. So it's encouraging that individual to actually work alongside that housing piece. And I would say that in terms of recovery safe, that is in the determination of the individual. It's left to their discretion. But in the ASAM criteria, Dimension 6 discusses a recovery environment. And many of the things that are part of this benefit, transition benefit for people who've completed treatment, really speaks to that in terms of assuring that they have housing, assuring that they have a transportation benefit, that they can move within the community, whether that is through a gas card or whether that is through a bus, public transportation. But medical assistance does not pay right now for rides that are not medically based. So if you're trying to get your food, if you're trying to get to a job interview, et cetera, that isn't something that they have access to. So that's really what this is meant to do, is support the individual after they've discharged from treatment, when they're newly in remission and trying to get a foothold in the community. Thank you for your time.
Well, that's very helpful, and I think what's gone on here is the whole committee is being enlightened a bit. Ironically, the people who testify here, who wrote this bill, who spend their whole life in it, don't get to vote on stuff. We have to. So the more we can learn, the more we can help and actually cause less unintended harm. So anyway, let's just with that, let's talk to, is it Ms. Grom? Are you here to? Thanks, Mr. Yeah. Thanks, Mr. Walsh. Ms. Grom, are you here? Are you going to offer your thoughts? You do everything. I don't ever want to see the list of tasks you have been charged with. If you ever quit, they're going to have to hire 4 people. So anyway, welcome to the committee.
Thank you, Mr. Chair. Appreciate the opportunity to just say a few words and want to thank the stakeholders and Senator Wiklund for their work on this bill as well. I would say certainly we have some concerns about the bill. We have a lot of questions as well. So we look forward to continuing to work with stakeholders on the issues, on the questions that we have. I'd say we agree with many of the goals of stakeholders here, and in fact, the idea of transitioning the system, moving away from that episodic model of care to a more long-term maintenance model is actually really heartening. That's really what our 1115 FCG demonstration is all about, and what the ASAM criteria are all about. It's thinking about ways to connect people after treatment and expand that recovery continuum so that people can have the supports they need to stay sober, and if they have a relapse, to get the support that they need to get back on track. So I think there might be some conversations we could have with stakeholders about maybe expediting some of those reforms in our 1115 demonstration instead of kind of creating a new policy and regulatory construct in some ways that this bill does. So we'll continue to talk with stakeholders on those. On the transition benefit, I would say our heart is there with you. We just need to work a lot more with stakeholders to understand kind of what the intent is here, who would administer this benefit, and then how it interacts with some of our current benefits. I think we've been working internally with our Children and Family Services area as well as our housing division to look at ways that even outside of this bill we could maybe create some administrative efficiencies and improve the way we administer some of our current benefits to get at what some of the stakeholders here are trying to do. So we'll continue those conversations. We're also looking and trying to pay attention to the pilots that are happening right now around guaranteed basic income in Minneapolis and St. Paul, and think that, this is, these kinds of services aren't just important to people leaving substance use disorder treatment, but other treatments and other situations that may be precarious as well. There are some concerns around some of the licensing changes, not all of them. I won't get into the weeds on those. Number one, it's not my area or my specialty, and I think we just have a lot more offline conversations that we can work through with stakeholders. So I'll stop there. There's a lot of technical assistance that we provided, and we'll continue our conversations in the weeks to come.
Well, I really appreciate that, Ms. Grom, and so I'm interested in things that, you know, if there's some policy changes that are without cost that make stuff better, I think we should be all over those. I have a question of an example of one of those, which on page line 16, it talks about that, it was mentioned in testimony last time, that if they don't get all the hours in, the 30, 15, or 5 hours, if they get 29, they get apparently nothing, or 15 or something. Is that going to have a cost? That paragraph 8. Do you know offhand? Just
Mr.
off the top of your
Chair,
head.
I'm not sure. What page are you on?
Page line.
Can you give me the page line?
Page line of the bill, line 16 to 23. 9. Page 9, line 16.
Okay, I'm just looking right now. Mr. Chair, I'm not certain. I would have to get back to you
All right.
on that. I don't want to give you incorrect information.
Sure. But it just, some of these things, yeah, and anyway, everything we want to do probably will cost money, but, so I have a lot of questions, but I guess we'll just hold on those. But I appreciate the beginning of the discussion. This is a significant bill. There's a lot of good policy and probably as many disagreements, even in the industry, about what makes the most sense to do, and Senator Wiklund is versed on that. But so, Senator Wiklund, as you work with the March and the rest of the groups, Teen Challenge and the department, let's just see what we can't get out of here that we can move forward with that can make a difference. And so I appreciate your experience and expertise in that. So, questions from members. Senator Hoffman.
Thank you, Mr. Chair. I think you're embarking on it. I think anytime you can get, Dr. Walsh with over 30 years of experience in this field to come in and have a policy conversation in the #1 rated committee that's out there, I think you're good. And then to have Zerbas and Delwu, who are the right players to having this conversation jointly with then, Ms. Grom, I think you've asked that question, and I think it's important because there is some really good policy stuff in here. We know the system is not coordinated. We know the system is not collaborated. And we know the system is not comprehensive. And those are the 3 C's that I've talked about for many, many years. And hence, back to your original conversation, how do you make this system a little bit better? Well, perhaps we elevate the priority from the bottom of a division to the top, like your bill sets out. And I think, where else can you have a committee conversation with these players on the table having good policy conversations? So, Mr. Chair, to your point, I think it's important that the folks that testified here should be helping mold and move this forward. And I like what I'm reading, and I like what I'm hearing. So thank you for bringing that forward.
I appreciate it, and thanks for the shout out on our #1. Oh, that too, the #1 thing, but about their restructuring ideas. And again, the restructuring thing is about making it work better. There's no criticism of anybody. Just, anyway. Other questions from members? Do I see any hands? Just to point also, in my hand here, I have the draft, the jackets for the Recovery Community Organization draft, which at the end will not look like that. But that's going to be dropped, and so we'll actually have a real live bill in front of us. But the people that are following that topic, the recovery community organizations, there's a lot of consensus that we can do something different. And with all respect to ARCO and Mr. Rutherford, and they started out with in the beginning, everybody who was being talked about was already members, so it was just simple, like, why don't you just keep doing it? And now suddenly there's several $1 million and growth, and I appreciate the tone that he's presented with me and the professionalism. But I think there's a consensus this time to find maybe some change in that model. So other questions from members at all about this? Super. And so I'm not trying to say there's never a chance to get any money on this, but I'm just trying to help folks understand. There's somebody should tell me how much money there is in this niche, and it's considerable. And so how do you make it how do we rejigger it to make it even go further? So, Senator Wiklund, you get the last word.
Well, thank you, Mr. Chair. I think that we've heard, good overview, and we've heard reasons for the need for this bill, and I hope that we can all keep working together and try to bring forward the things that are, like you say, immediate and low or no cost, and also, keep in mind things that could really add value if we do have some additional funding. So
Very nice.
I'd be happy to keep working on it.
Yeah, and I know there's a scat of clones around, and I think I'm on some of
Yeah.
those at least. And so Senator Wiklund did, and so if to my staff and others can just be sure that Senator Wiklund's kept apprised of that. So when those hearings happen, that she can kind of coordinate a lot of this information gathering, so.
Okay.
Very nice, thanks for that. Senator Fateh, why don't you go to the table? And I think we'll work off Senate File 3389 to start, just to be sure we get through the meat of the business. So, yeah, let's do that. And then let's see one unique testifier, Zania Harut, and we'll make sure you get to say hello if nothing else. So what we want to hear from you. We have a good amount of time, Senator Fateh. And so you have a presentation in mind, and eventually we'll do up some amendments, which I don't know if I have those, but we'll sort it out. So welcome to the committee, Senator Fateh.
Thank you, Mr. Chair. Over the past few months, my office has been contacted by many human services providers and clients. And one of the areas where providers and clients' concerns stood out to us was the area of customized living, specifically customized living under BI and CADI waiver recipients. We are seeing a lot of the changes that reflect a broader trend away from customized living as the preferred mechanism for clients under these waivers who are not elderly. And DHS has confirmed to us that both the state and the federal level, there is a trend leading us away from customized living for these clients. However, at the same time, we know that we have many providers and clients in this category. So what I'm seeking to do today with these bills is to ease the burden on the providers and the clients as policy changes are taking place. Many of these providers will ultimately transition to services under a different licensure, but we know that process will take a long time. And in the meantime, we need to make sure that customized living does not collapse from under us, which would leave many of our clients without housing or services. So for SF 3389, one of the most frequent concerns we have seen is that folks are being denied services arbitrarily due to not being in the assessment, which we can understand. We want to make sure that people are not getting the services they don't need. But without providers not being able to see the plan, they don't know what to expect. That's the first part of this bill. It protects the client privacy while allowing providers to see the support plan for a client so that everyone on the client's care team can be on the same page on day one. The second part of the bill requires assessors to consider provider feedback. Providers spend hours and days with these clients, and they get to know them far better than an assessor could. We don't want these providers, obviously, to dictate a client's assessment, but their feedback should be taken into consideration. And the way we do that in this bill is by requiring assessors to consider the feedback of providers upon reassessment and to give an explanation if they disagree. And with us today, we have Amal Ahmed from Allied Group Homes and Bao Vang from RPAMN.
And so who would you like to go first, Senator?
I can go first.
Okay,
Bao.
welcome. Yeah, welcome to the committee.
Thank you. Thank you, Mr. Chair and members of the committee for having us today. I wanted to start off by thanking.
Introduce yourself, though, please.
My name is Bao Vang, and
you.
I'm the interim executive director of RPAMN, which is a newly formed nonprofit organization representing over 200 providers. And we are really grateful for Senator Fateh for carrying our bill today. So we want to thank you and thank the committee for giving us the opportunity to testify in support of Senate File 3389. I'm just going to talk a little bit about our organization and our mission. So our mission really is to provide a platform for our providers, and particularly residential care providers, to come together to facilitate a positive outcome for people that we serve in our community as we strive to create meaningful impact by fostering alliances, advocacy for our members in our community, and leadership development. And so I have here today with me a provider who's going to speak by using her own experience in support of Senate File 3389. So I'll turn it over to Amal.
Welcome, Ms. Ahmed.
Mr. Chair, members of the committee, I apologize, I'm very nervous.
We're just a bunch of people up here, so you just talk like you're talking to your friends, okay?
So my name is Amal Ahmed, first name Amal, A-M-A-L, last name A-H-M-E-D. I am an executive board director of RPAMN, registered nurse, clinical nurse supervisor, and director of nursing of AGH. I'd like to thank you for the opportunity you given me today to speak on Senate File 3389 regarding the use of the men choice assessments in our facilities. I'd like to highlight the importance of having access to the men choice assessments, speaking from a personal standpoint. This assessment, coming from a nursing perspective, is like a blueprint. So this is a starting point where we look at how we need to meet the care needs of the resident that we are going to take in. When we don't have this assessment, it puts us in a position of liability in terms of a risk factor for safety in regard to the care needs that the resident requires. So with saying that, it's very important because this assessment informs us where we need to focus the care plan for the resident to be person-centered in terms of the cares that they will be getting in the facility. I'd like to share with you a personal story where I had to accept a resident without the men choice assessment, in which I've requested on multiple occasions and was denied on multiple occasions. With respect to that, the resident had an extensive history of drug use and abuse, specifically opioid and methamphetamine. So I wasn't aware how critical this resident was with their issue with relation to the substance use and abuse. And one day we found this resident upstairs overdosed in their room. Luckily, it was around the time of medication administration time, and the staff was able to summon an emergency response, and it did not end up in a fatality. This happened to us twice. And had I had the men choice assessment, I probably would have had the information I needed to rightfully curate a care plan that would have at least put in place something where we could monitor and supervise the resident for their safety. Furthermore, when we have a resident in the home, and we've had residents that stay with us for years, we know what they need and how they need it and where they are thriving and where they're not thriving. It's important for the assessor to take into consideration the nursing judgment, recommendation, and assessments when providing a reassessment on the men choice assessment. And if they do not take the recommendation, then it's also important for that assessor to provide a written explanation as to why our recommendations were not taken into account. So the men choice assessment is a vital piece in creating the framework of a care plan for the resident that's living in the home. And without access to that, it puts us in a very tough position, especially the resident, which is unfair for them. And I thank you, Mr. Chair, and members, and I'm happy to stand for questions.
Thank you, and members, that's the base bill that we're looking at here. So let's take a minute and see if there's any questions about that. At the end of the discussion, I'll let DHS speak up. We're going to raise some other points that are probably controversial, and so they can just cover them all at once and work with Senator Fateh. And actually, I have an amendment that will be very controversial. And so one of my favorite topics is min choices. I don't know, I'm going to be the old guy at the end of the bar talking about $360 million a biennium we spend on min choices. It seems like a lot of money to me, Senator Hoffman. Does that seem like a lot to you?
I don't know, Mr. Chair. I think it was $1 billion over a period of time, and those numbers, I believe, I sent to you in a spreadsheet. But that's just an assessment, Mr. Chair.
Yeah.
It's not about services.
That's
This
not
is just,
treatment
this
or
is just
helping folks?
assessing $1 billion in assessments.
That's
Right?
a lot.
That's a lot of money. So you're
Anyway,
to your point, Mr. Chair.
And so Mr. Monahan, at the end of his career, will get some kind of a plaque for men choices, heroism or something. We've spent a lot of time on this. Anyway, so that's the base bill. Senator Hoffman, do you have Senator Fateh, do you want to do your amendment? Are you did the A3? Is that yours?
Mine's A2, but we can do,
Okay, Senator Fateh, take your amendment since it's your bill up there, and then we'll. And I just, two of these, just so you know, for full disclosure, two of these amendments are bills in other committees, and I just give people my word that unless they're heard or waived, that this committee will not advance that language out of here in our policy or other omnibus. So that's my disclaimer. So Senator Fateh moves the A2.
thank you. Yeah, I'd like to move the A2.
I believe you have a testifier then. Go ahead.
Yes, Mr. Chair, thank you. Minnesota offers the choice of self-directed care, meaning people on waivered services can hire their own staff. FMS, or financial management services, are provided by third-party companies with contracts with DHS to manage HR responsibilities of hiring on behalf of clients. Right now, the list of FMS providers is fixed based on an RFP that lasted 1 month in 2016. We think that other companies should have the opportunity to become FMS providers if they meet the stringent criteria necessary to qualify. This bill will simply open up the RFP continually and creates consumer feedback as part of the consideration for contract renewal. And so we have today Musab, who's going to testify.
Welcome, sir.
Thank you. Mr. Chair and esteemed members of the committee, thank you for letting me testify.
Oh, you have to introduce yourself, please. So we want to know who you are.
Yes, my name is Musab Khalif. I'm here representing on behalf of my family's company, Midwest Home Healthcare. And I thank you for letting me testify today on the FMS amendment. I will give a brief overview of the FMS program and its timeline, and relay some of the concerns and issues we have with its implementation. The timeline began on March 25th, 2016, where DHS gave an introductory presentation on the FMS program. Then on May 2nd, 2016, the FMS RFP was published for the first time, which was then closed on June 15, 2016, giving agencies only 1 month and 13 days to complete the 12 requirements in the RFP process. Now, given how extensive and time-consuming these 12 requirements were, it was near impossible for smaller and less connected agencies to qualify within this short time frame. So after some pushback on this, in October 17, 2016, a second FMS RFP was published, which on November 7th, 2016, the second RFP was closed. This time, agencies were only given 21 days to complete the 12 requirements that was still part of the first process. So none of the underlying problems with the first RFP process were fixed in the second RFP process. For example, agencies did not receive ample time to complete their readiness review, which can be a very long and arduous process. Fed up with the process, various individuals and organizations have come forth decrying the 2016 FMS RFP for lacking diversity and excluding small mom and pop shops like mine. 2 minority agencies were recently awarded the FMS contract without the traditional and open RFP process in response to these pressures. By opening up the RFP to more agencies, we believe the DHS was heading in the right direction. But by limiting the number of RFP applicants to just 2 and using an opaque process, it caused agencies and constituents to lose faith in the system. This amendment before us today will ensure a more fair and transparent process that will naturally create a more diverse representation of FMS providers from all backgrounds. By allowing any qualified and willing agencies to become an FMS provider at any time, we will have an open process. Furthermore, an expanded list of FMS providers will ensure a more competitive business environment, thus mitigating the risk of consolidation in the industry. Finally, and more importantly, the clients that we serve will be afforded more choice for culturally appropriate FMS providers under this bill and amendment. So I thank you, Senators and Chair, for letting me speak on this, and I will happy to answer any questions you guys have.
Questions from members? Senator Fateh?
Yes, as Musab stated, two entities or two companies were awarded the contract or given the ability to become FMS providers, but maybe in the spirit of diversity, right? But it wasn't an open process for everyone else. So simply, we want to open up the process for other small companies like Musab's.
And I will make a prediction, Senator Fateh, that the department, if this can be successfully figured out, will have some technical assistance that will make it look a little differently. But I think the idea is there that, and I think as knowing this is a kind of a work in progress bill, that we'd like this to be discussed more, and if there's not some fair and way to preserve against fraud and all that, but have quality individuals to serve everybody. So I'm comfortable supporting that. Any members have questions? So Senator Fateh renews his motion that the A2 be adopted. All in favor say aye. Aye. Opposed? Thank you. Senator Hoffman.
Mr. Chair, I have in front of you the A3 amendment.
Senator Hoffman.
Thank you. You know, we've been talking to DHS about a broader trend away from the customized living for the BI and the CADI waiver recipients who are not elderly, right? This is what we've been in conversation. It's reflected in both federal and state policy making. However, Mr. Chair, our state has many brain injury and CADI clients who are not elderly who are currently receiving services under customized living. Some customized living providers will switch to the community residential services under 245D. So do I want to give people time to look those statutory requirements up, Mr. Chair, or should I just keep going? Others will continue to provide services under the AL licensure. But this amendment, Mr. Chair, makes a couple of changes necessary to ensure continuity. That's kind of within the 3 Cs, Mr. Chair. For those who are transitioning to community residential services, we know there's a backlog at the Department of Human Services, and this amendment will make sure that those who are currently providing services under the CL side of it, the customized living, would be able to transition to CRS by extending the exception to the corporate foster care moratorium to 2024. It also creates a competitive grant program for Department of Human Services to work with Providers Association and an outreach and education to make sure, here's your technical assistance, that there is support for those who are transitioning, Mr. Chair, to the 245D side of that. And so for those that are staying on assisted living, CMS is really moving away from the customized living as a mode of services for people under 55. Now, there was an exception that was granted to providers and clients who are already working within customized living, Mr. Chair, but however, because of the way that we set up the exception in our state's law, providers and clients might no longer qualify for the exception if they move. This is key, and this happened in your own backyard. Because many providers are renters, this means that their clients may lose services that they are happy with simply because a landlord decides not to renew the lease. This amendment extends that exception so that existing providers are grandfathered in even if they move. This amendment increases the dependability of services while it preserves the spirit that we intended on the CMS policy change, Mr. Chair. So with that is your A3.
Senator Fateh, you favor this amendment?
I do favor this amendment, yep.
So just as a preliminary, I've got some of the early DHS TA for this amendment, Senator Hoffman. It's going to be thick. And so I remember these discussions, but these need to be discussed again. I think that this probably shouldn't become law the way it is, but I think it absolutely needs to be discussed. And I think that the moratorium was there, but there's all kinds of ways to circumvent it, and we should be honest about that and see how we intend that those exceptions would be allowed. And if there's a mechanism to do it more thoughtfully and intentionally. So for that reason, I support this for today. And Senator Hoffman, if you wouldn't mind working with Senator Fateh and the department to see if there's some way that this could be made doable. This is also, I think, in the licensing committee. And so if it has to escape the clutches of that for us to actually take action beyond this committee to move it out. But this way, at least when it goes there, you'll have a plan. Senator Hoffman.
So, Mr. Chair, from here, we would actually pluck this out, kind of like that division, move it up, but we would take this and go over to licensing with it, and then it will come back by itself? Is that what you're planning, or would you plan on rolling this into a larger discussion?
Senator Hoffman, it wouldn't really matter. It wouldn't go on its own. It would be part of some larger bill, I'm sure. But with the homework, this lets you get going on the work now, so that instead of waiting for a hearing and licensing and saying, oh, this doesn't make sense, we're not ready, it can be ready for whenever that hearing occurs. If the hearing does not occur, or if it's not waived, it will be a nice exercise in learning about government.
I like that, Mr. Chair. So, yeah, with that, I think that makes sense on the pathway, and I look forward to working with Senator Fateh and technical assistance.
Speaking of the chair of that committee, Senator Hoffman, Senator Benson.
Where is she?
She's
on
right
the
here.
thing.
She's in the
Senator,
ether.
oh, there she is.
Hi.
I just was looking to the left, Michelle. Nice to see you.
Hi, sorry, I am not in committee today. Senator Abler did speak to me about some licensing issues, so I'll coordinate with Mr. Yates to make sure that provisions that relate to licensing get heard appropriately. Okay?
That's perfect. So, and that's our intent here too. So we're, it's kind of like there's two clones of this. So, and maybe it can be in pretty good shape by the time you get it, Senator Benson, that it would actually be something we could do. So any questions about that? So Senator Hoffman renews the A3. All in favor say aye. Aye. Opposed? That's that. And I have an amendment. And this is an amendment that I hope does not become law. But I thank you for Senator Fateh for introducing it. I stole one of your bills. So the A1 I'll offer, and this says you can't have any private case managers, which is a little extreme. And so if we just brought this forward, then all the private case managers who would say, we're good ones, would say, don't get rid of us. But Senator Hoffman, Senator Fateh, there are some case managers that are private that aren't doing a very good job. In fact, I ran into one of those in my own district. And when I asked my county, who is a fine county, and I have high confidence in them, like, there's a problem with this private case manager, they go like, oh. Well, I say, well, whose job is it to oversee the private case managers? And they goes like, I don't know, what do you think? Is it, so they ask some questions and then they really, nobody's watching these private case managers. That was my takeaway in that study of an N of 1. So based on an N of 1, I concluded that there's a gap. But actually, Anoka County probably has more private case managers than one. In fact, they have a whole bunch. And so my question is, who is minding the store on what they're doing? And I think Senator Fateh, you said very well at one point when we discussed the ARCO thing, that elected individuals with a rubric of, you got county commissioners, you have divisions, you have checks and balances, you have county case managers that are employed by people who are accountable to us, and then you have this. And nothing against private sector. I'm a private business person, Senator Fateh. But they need to be accountable to somebody. And so the question I hope that we get out of this one is, who's in charge of them? And so that's the question I bring by bringing the A1 amendment forward as pretty much a work in progress. Senator Fateh, do you mind if I tack this onto your bill?
Oh, yes, absolutely.
Any questions from members? All right, I'll renew my A1 motion. All in favor, say aye.
Aye.
Aye. Opposed? All righty. So, who's here from DHS today to talk about what we've just given you as this that's a little stone soup, I think, is what it is today. So,
Yep.
Is it Ms. Grom again or somebody else?
Mr.
Oh,
Chair.
there you are. We should just ask for you about everything. Long-term care, oh, Christy can do it. Anyway, welcome back. I'm sure you have many thoughts about this, and you can say as much or little as you care to today. And we duly intend to work with you on this, but now we've just got the discussion going, so go ahead.
Sure. Well, thank you, Mr. Chair. Christy Grom with the Department of Human Services. So we are continuing to analyze these bills. I know some of them are pretty new, and so we don't have full analysis and a full understanding of the impact. Some of them I think were, aligned with the policy direction, and we have appreciated the meetings that we've had with Senator Fateh and many of the constituents and testifiers today. So we do hope to continue those conversations. I would say we have probably the two that is so far I've identified some concerns with are the changes related to case management, the amendment that you were just mentioning. So on that one, CMS has directed Minnesota to allow for subcontracting of case management as a way to expand provider options and support a person's choice of case manager. So this is something that we've been working with CMS on to improve our system. There is a responsibility that lead agencies are accountable for the quality of case management provided by their subcontracted case managers. And so we do work with subcontracted case managers as well as our county case managers on a regular basis to provide supports and guidance and make sure that they have the information they need to do a good job and provide quality case management. But I think we have some potential federal implications here with this change. And like you mentioned, we can continue to work on that. And then there was the changes related to the long-term care consultation assessment. We can continue to have conversations about that too, but under current law, I mean, providers should, it was kind of noted in testimony that there was an issue with receiving a copy of the assessment or the full MnChoices assessment, and that's something that providers should be able to get as long as they have a release of information with the client. So I'm not sure what happened there, but we can look into that issue. I think we do have some concerns about the administrative complexities that this would add for, an already stressed lead agency. So we'd want to have conversations with providers as well as lead agencies. I know lead agencies they're already able to accept documents and from other providers when they're doing assessments or reassessments. And they are, I think, at times struggling to really manage to make sure that they're making the assessment and doing the support planning in a way that's person-centered, which is really their goal, and not having undue influence where, a provider might want to authorize certain services or increase a budget. And I think, some of the grants and the slew of bills that you've been talking about today might help with some of that. But overall, we'll just have to continue looking at these bills and analyzing and continue to work with you and with stakeholders.
Well, and I appreciate that, and let me just dialogue with you a little bit about where I see the discussions as being suitable, and I think Senator Fateh and his testifiers have some thoughtful ideas here. I remember the discussion about inordinate feedback on the assessments by providers. That's been discussed for 15 years, I think. The concern, but sometimes what you do is you maybe get some rather unusual assessments that just don't make sense. And it seems like there should be some way, just even as a one-way communication before it's finalized, they would go, what are you thinking? And Senator Hoffman, we just had some experiences with some individuals where they've, actually we'll talk about that in a second, where with the new assessment, MnChoices says 24/7, and they get no overnight, I guess 6 hours a day and no overnight, like what? So that's what provokes my interest in this in particular, and I think is shared by Senator Fateh, so we can sort that out. The case management thing, you can virtually ignore the A1 the way it was, but what I want to come out of that, it was just a handy amendment that provokes the discussion. Who is in charge? You don't have to answer this now, but let's clarify, if it's not clarified in statute, who is overseeing that? If there's a complaint, where do the people go? Oh, you go to the owner of the company. Like there's a case manager, you talk to the owner, and it's not really a feedback loop. There was a circumstance about a bathroom remodeling, and it took 2 years, and then still didn't get done, and the women barely had a toilet, and it was just amazing that we could, it just was amazing to me. I'm moving my hands again. And then on this FMS bit, I know that you've been very thoughtful about that, but I think if you can revisit that and see what makes sense about, if it's quarterly or every 6 months, you can look at a new batch of folks or something practical to not overload your work, and then What was yours, Senator Hoffman? You got, go ahead, Senator Hoffman.
Customized living, Mr. Chair.
Oh, the
looking at
moratorium.
The
thing, yeah. So
moratorium
we
piece
talked
on
about that. You're gonna
CRS.
work on that. So Senator Hoffman, there was an example that we just ran across where it was just preposterous.
Yeah.
And, well, I'll let you tell the story.
Well, the fact is, here's a gentleman who has been, he's an elderly gentleman with elderly parents, right? That's the one you're talking about,
Yeah.
correct? And the case manager, which is a third-party case manager, absolutely, it says right in the Min Choices assessment, the things that the person needs, but then the decision came from somebody else that said, no, we're not going to give those to them, and they actually had to, I believe, seek an attorney, and just so happens the attorney they got was the same attorney that worked on that. Remember the Mito case, this Jensen settlement thing? You remember that?
Is that helpful in this discussion?
I don't know, but but my point is, the other thing too, Senator Abler, that draws, last year, we were in a conversation about when systems are changing, are we thinking about the system itself? And the answer came in a conversation, and I remember this like it was yesterday, and an individual said to you, well, let me explain to you what waivered services are, Senator Abler. And that same individual said, well, you can always appeal the process. The burden of proof always goes back to the parent or the client. And to my response to you at the time and now is that really thinking of how the system's going to approach? And so I think your question on the table and what Senator Fateh is bringing is really driving at, did we think systemically about how the system's going to look? And I would question that, right? I mean, I would question that in the sense of now this gets the question back onto the table saying, and it's time to look at it. And I think having Christy Graham on working on this is absolutely the right thing, to do on this because, we will get something at the end of the day that's going to look to the importance of the individual with disabilities to their unique and individualized needs.
Yeah. Senator Murphy.
Thanks, Mr. Chair, and thanks, Senator Fateh, for bringing the proposal forward. I was grateful to hear from your testifiers, especially the registered nurse, just saying. Senator Fateh, I am wondering if, because there's a lot of discussion happening here, if you could just reiterate for me and for the committee your overarching goal in bringing this proposal forward. I know that it's going to carry now a number of amendments. Yeah. All good, and I, can hear the purpose of the discussion here, but it would help me if you could just one more time, reiterate your goal in bringing this forward as a part of this work. Thank you.
That may be the best question of the day. So Senator Fateh, kind of bring us in for a landing, and maybe in your closing comments you can do all that. That'd be perfect. Thanks.
Absolutely. So the first part is allowing the providers to access the support plan so they can get the information that of the clients. I think that we're able to provide, or we're able to protect the client's information while at the same time being able to better serve them with the providers being able to access information. The second part of the bill is just allowing the providers to give feedback to the assessors upon reassessment. So I think those are the two main points.
Senator Fateh, why don't you just step back and even outline what sort of providers these are and the services they're providing and what their clients are like?
Yeah. I'll let one of the providers speak to that
just
better
kind
than I can.
Just a big overview. I think that'll help us, and then we can get grounded on this bill.
Okay. Mr. Chair and members of the committee, my name is Zania Harut, and I'm a registered nurse also, public health nurse, and director of nursing at Affinity Care. So we are residential providers. We provide customized living services in a residential home setting, kind of like your own home. So it's not a institution or a larger building. We provide customized living and assisted living services in a house. So we have we have low ratios, and we have individualized care for individuals with mental health concerns as well as elderly individuals. So.
Very nice. So with that, we'll lay this bill over. And Senator Fateh, let's take up your other one now, just for a couple minutes. And I think you have two testifiers for that as well, Ms. Vang and Ms. Harut. Is that right? So if you want to introduce your bill, so move 3390 will be before us.
Awesome. Thank you, Mr. Chair. Unlike other waiver services, customized living rates did not follow the DWRS or Disability Waiver Rate System framework, which is tied to inflation. We all know that the cost of labor has gone up, and a lot of workers require higher wages. Right now, the state is reimbursing providers at far below the market rate for labor, which makes providing services financially unsustainable. This bill would simply increase the rates for BI and CADI waivers, BI and CADI to match the increase that was passed for the elderly waivers last year. So again, for this, we have Bao Vang speaking and Zania Heyrut also as well.
Okay, well, thanks. And briefly, we're at grave risk of actually getting done on time today, so I'm not sure what we'll do about that. So welcome again.
Thank you, Mr. Chair and members of the committee. Again, my name is Bao Vang. I'm the Interim Executive Director of Residential Care Association of Minnesota. I am here today again to speak in support of another bill, the 3390. And as Senator Fateh had mentioned, a lot of our providers are struggling. We are going through unprecedented time in financial hardship. So as you can only imagine, the competition for labor today is really significant, a really significant challenge. So for example, pre-pandemic, when we hire someone to work for our facility that don't have any experience, we typically hire them at about $13 an hour. Today, our providers are struggling to maintain and recruit at an amount that is about $17, $18 an hour. Also, because we are small residential care providers, with the rate that has not increased for a number of years, coupled with a reduction in rate cut, is giving our providers anywhere from 60 to 70% cut overall. This is pretty significant, and as I'm sharing with you today, many of our providers are struggling, not knowing what the future is going to hold for them. And some of our providers already closed their door. And they provide a unique niche and services to members of our community, predominantly people of color in our community. And so I am here today alongside with one of our providers who can give you her own personal experience as far as what this economy is doing to small providers. Zania?
Welcome back.
Yeah, Mr. Chair, members of the committee.
welcome.
Again, my name is Zania Heyrut, and I'm the registered nurse. So I can speak to what has happened with our rates and everything. So our rates have been cut, but our costs are going up. Like Bao mentioned, we have seen an increase of 20 to 40% in what staff are asking for to come work in our facilities. And so the rates for CADI and BI have not been increased by much in over 7 years. And so we are essentially in a crisis right now with what's going on. If we are forced to close our doors, that would cause even more homelessness crisis here, and it would cause increased people to be transferred to the hospitals, which are already at capacity, and that's a higher level of care that costs way more than just residential care. So, I'm here to speak today on what that looks like, and thank you so much. Mr. Chair and the members, I'm happy to stand for questions.
Well, that's very helpful. So you're serving CADI and TBI individuals who are not on the waiver, or they're on the waiver?
They're on the waiver.
All right, and if they did not live with you, they would go to to an intermediate care facility? Is that where or a nursing home?
Nursing homes or hospitals.
Yeah.
Mental health hospitals.
Yeah, all right. No, I mean, we've just been challenged over and over with the spectacle of workforce and the challenge of it. So, the questions from members? No?
Thank you, Mr. Chair, and not a question, but I think it's important to to reiterate or to say that it is not just the cost of moving somebody from home to either a nursing home or to a hospital that is the downside of the rate issue that we're describing. But for many, especially a longer stay in a hospital, increases risk of all sorts of adverse events, including infection, and skin integrity issues that could lead to a much worse condition. And so I think in addition to wanting people to be in their homes, in the place where they have the most independence, we are also, if not paying attention to this, creating a situation for people who are already struggling with their health to be put into a situation where their health is more compromised. Thank you.
Very well said. With that, we'll lay that bill over. Just a little bit about next week. On Tuesday, we'll be taking up competency restoration. We'll be hearing, I don't remember the two bill numbers. I'm carrying one. Senator Senjum's carrying one. He's carrying the task force bill. I'm carrying the one from the county attorneys, which is many similarities just to deal with. And so that will be the entire meeting. And then on Thursday is Homeless Day at the Capitol. Senator Dibble has a bill. I don't know what else we're going to do about that day, but that's going to be the topic. Senator Hoffman?
Thank you, Mr. Chair. I just, the last couple of weeks, Christy Brown from the Department of Human Services, their policy bill on community sports administration, technical policy, it's like, okay, we'll wait, we're good. I just want to make sure we're still in the queue, so
Yeah,
whenever you're ready,
We're
Mr.
taking
Chair.
that up on next Saturday.
Okay.
So we will
Ms.
do the
Crom, are
policy
you-
bill. And just, I really appreciate the work of the committee. We've actually done some really nice collaborative kind of work here. And so, am I 45 seconds early? With that, mark your day, we're adjourned. Thank you. Yeah.